Let's talk consults, shall we? We need consultants frequently. And depending upon where you are, it's almost a standard of care to get consultants on board. Where I live, as the saying goes, you can't swing a dead cat without hitting a consultant, right? So there's a lot of consultants where I practice. You're never wrong for requesting a consult. Sometimes if the consultant deems that they don't necessarily need to follow the patient, he or she still needs to tell you and they still need to evaluate, but in the documentation they may say, we don't need to follow as outpatient, something like that, okay? But there's a series of steps, a protocol you should follow when you are responding to a consult request or making a consult request. Let's say we are placing a consult order. First thing, one, you need to place the order in the EMR, and then that almost always obligates you to attach a physician or a physician team to it, right? So you identify who the consultant is on call, put his or her name in the consultant box, drop the order. Now, is that enough? No, it is not enough just to drop the order, although there are some co-management situations where you don't actually need to call the consultant. But by and large, what you need to do then is you've got to call or communicate with the consultant from whom you're requesting the consultation. How do you formulate a consult question, though? I recommend that you keep it brief and focused on the exact question you want the consultant to address. Sometimes these patients have got a ton of things going on. Sure, there's a lot of things going on that's wrong, but the consultant doesn't always need to know about everything that's going wrong. And the consultant doesn't always need to know the entire story of what happened in the hospital. Nor do they need to necessarily know the entire history. The consultant will probably get that history themselves. So you can keep a consultant communication pretty brief. Let's say someone comes in, it's obvious they've got an infected gallbladder, right? So you're going to call general surgery, you may call GI. If they're septic, maybe you'll call ID. And this will come with experience, but you're going to want to imagine what the consultant would have to offer and then kind of give him or her the information that they kind of want to know. This may take a couple years of practice before you know what they're looking for. But let's say you're asking a surgeon to weigh in on an acutely infected gallbladder, right? So they're going to want to know whether or not this is something that they should take out now, or is it something that they should wait? Is the patient stable? Are they unstable? Are they safe to undergo surgery? You want to anticipate what information the consultant may need. And again, this comes with experience. So let's say you call a surgeon for an infected gallbladder, right? You don't necessarily have to go through the history. In fact, I wouldn't. Okay, I wouldn't say, 3 days ago she started feeling nauseous, and then, she started vomiting, and then she started to feel unwell, and then she tried Pepto-Bismol. You don't need to do all that. You can be brief. I have an infected gallbladder. Patient is currently febrile, hypotensive. We've got antibiotics going, and that can be it. Those pieces of information would tell a surgeon, okay, all right, well, it seems like they're not even stable for surgery, so we should probably try and give them some antibiotics for a little while. Hopefully they get clinically better, more stable, and then we can talk about removing the gallbladder. Give that information and then let the consultant evaluate. So then you do the same thing for the other consultants, but you want to tailor the question based on what their field of expertise is. But remember, you can be brief and then lead with what you want them to evaluate. That's really important. Don't call the general surgeon and say, hey, Mrs. So-and-so is an 85-year-old female with a history of COPD, and she had a stroke, she's got AFib, she had sepsis 10 years ago, she had a knee replacement. Like, you don't need to do that, okay? And you don't need to say, yeah, and then starting 5 days ago, she started to feel unwell. She's felt this feeling before. She took some Pepto-Bismol. Don't do that. It's too much. Go right into it. I'm requesting a consult for an infected gallbladder. Boom. Keep it brief. They're busy. Along with your consult question, you should also paint a picture of how urgently this is necessary. Ideally, you'd be able to kind of get an idea of what's going on with your patients before noon, And then ideally call the consultants as early in the day as possible, especially if you want them to see the patient the same day. Sometimes things happen during the day where you can't call the consultant until the afternoon. You can't realistically expect him or her to see the patient that day unless they're really unstable or unless there's some kind of an emergency. So try and, as much as you can, call earlier in the day, or at least paint a picture of how urgent it is. Sometimes you can come right out and say, hey, this is a non-urgent consult. This can wait until tomorrow. Patient stable. Great. So they'll put them on the list and they'll see him tomorrow. So what happens next, the consultant is supposed to evaluate the patient, okay, and then they're supposed to formulate a plan from their standpoint and then write it down, and they're supposed to contact you and just say, hey, I evaluated so-and-so, and this is what I think, this, okay? And then at that point, be very, very clear who is going to deploy the recommendations. This is really, really important. There have been lots of cases where the primary team thought the consulting team was going to put in the order, and then vice versa. The orders weren't done. The patient didn't get treated for like a full day. They got worse, okay? And that, I believe, has led to some lawsuits, okay? So there are some institutions where the consultants only recommend, and then the primary team has to put in the orders. But there are some consultants that say, hey, I recommend this, I already put in these orders. We're going to take them to the OR tomorrow. I put in NPO at midnight, things like that. But it doesn't hurt to confirm. Just say, oh, okay, thank you very much for seeing this patient. You want me to put the orders in, or you got the orders? And then get the confirmation, and then just as a good form at the end of the day, look and make sure those orders are in. We're all human. Sometimes we forget to put in orders. Okay, so consultant evaluates. The consultant contacts the primary team with the recommendations. Both teams should document that they spoke with each other, okay? And then you should verify who's going to place the actual orders, who's going to do the intervention. And then spin back around and make sure that intervention was done. And then the consultant will tell you we'll follow or we don't need to follow. This can be followed as an outpatient. They should make recommendations both for what's happening in the hospital. If they're not going to follow, they should make recommendations for once the patient discharges, we want them to follow up at this time or follow up with this person, and these are the interventions we recommend. Or this patient needs this procedure at a later date, things like that. Okay, so what do you do if you're the consultant? Pretty much the same thing. The one thing I want to emphasize is that if another team is consulting you, so if they're placing a medicine consult, it's maybe some kind of a surgical team. If you have a chat system, then chat them, but you're never wrong picking up the phone and talking. I think that's actually kind of the best way to do it. I like chatting, but I also dislike chatting because it can really pile up a lot, and sometimes chats just flow and they can kind of pass you by and you forget. So you're never wrong for picking up the phone and calling. Okay, that's pretty good form. And nobody should get upset if you want to talk on the phone. This is actually just kind of how business is done. It may not be this way 20 years from now. And I've noticed that people who have been practicing longer, maybe they may prefer like phone or face-to-face. And people who are maybe like a little younger don't mind the chat as much. But either way, you've got to communicate and document that you communicated. Oh, and this is also very important. When you don't think you have anything else to offer, if you're the consultant, and if you're not going to follow the patient, you've got to document that you're signing off. It's really important that you put in your documentation, I'm going to continue to follow, or here's my recommendations. Call us back if you need anything. However, we're not going to follow. Sign off. Okay? That's a critical part of the consultation process. Put that in the note. What's a curbside consult? I'm sure you've heard that term before and you kind of know, okay, that's kind of an informal consultation, right? It's not really a formal consult. Yeah, that's right. It's informal, but it's so informal that it shouldn't be documented, okay? It's so informal that no order trail or paper trail should exist at all. It's an informal question not attached to a patient chart. No order is formally requested. The consultant does not officially get on the case. This is really, really important. So if you go to a consultant and say, hey, here's a quick curbside. Let's say I had, no, okay? You don't want to say, hey, can I get a curbside on Mr. So-and-so in room so-and-so? Just so you know, he's a 37-year-old male who's got this, and then like attach the patient chart. Don't do that, okay? Because at that point, you're asking for an actual formal consultation. When a consultant evaluates a patient, he or she is obligated to drop some documentation, okay? But in a curbside, like none of that happens. No relationship is formed, okay? So be very vague. Don't attach patient chart. Definitely do not document that you spoke with a consultant about this issue. Very vague, like, hey, ID, let's say somebody went swimming for 2 hours in a pool that's inside a cave, and then later they saw bats flying around, and they're not sure whether or not they drank bat poop. Could they have rabies? Right? And so even if your patient swam in a cave with bats and all of a sudden they're foaming at the mouth and they're like pushing away water, okay, if you're just kind of asking for a curbside, in that particular case, you should probably get a formal consult. But if you were just to say, let's say I were to swim in a cave with bats, could I have rabies? Like, do not document that you asked ID. Do not attach the patient chart. Don't even mention a patient name or demographics or anything. Now, if it sounds kind of hardcore, sometimes the consultant will say, do you want me to formally consult? And then, you say, yes, please. And then you drop the consult order, and then you formally say, I asked ID about swimming in a cave with bats. Is it rabies? So that's how I think you should approach whether or not you're consulting somebody or you're acting as the consultant. If you have any further questions about consults or things like that, just put them in the comments.